There's a particular kind of moment I've seen more times than I can count. A patient sits across from me, tells me they've been noticing something for a while, months, sometimes longer, and then says the words that I hear almost every single week in my practice. I figured it was just getting older, and sometimes they're right. Aging is real. The body changes. That's not something you fight or pretend away. But here's what most people don't understand, and what I've spent the better part of 2 decades trying to explain to patients over 65. There is a difference between aging and deterioration. A real, measurable, clinical difference. And the body almost always tries to tell you which one you're dealing with. The problem is that the signals are quiet. They don't arrive with sirens. They arrive looking like fatigue, or a little stiffness, or a moment of forgetting something you absolutely should have remembered. The body compensates brilliantly. That's what it does. It reroutes, adjusts, finds workarounds. And for a while, that compensation is completely invisible. You feel almost fine. You function. You get through the day. You assume the small things are just noise. They're not always noise. 7 specific symptoms have stayed with me over the years, not because they're rare, quite the opposite. Because I've watched patients dismiss every single one of them, sometimes for years, and the cost of that dismissal was significant. I'm not going to list them the way a textbook would. I want to explain what each one actually means inside the body, why it shows up the way it does, and why it becomes more dangerous, not less, the longer it goes unexamined. Let's start with one that almost no one takes seriously. You're walking, parking lot, grocery store, your own driveway. And for just a fraction of a second, your vision does something odd. Not goes dark, not doubles. It just stutters, like a frame dropped from a film. You blink, it's gone, and you keep walking because it lasted barely long enough to register. No pain, no dizziness, just that tiny visual interruption, and then nothing. That is not nothing. What I see clinically in patients who describe this, and they almost always describe it apologetically, like they're wasting my time, is something that deserves immediate investigation. That brief flicker, that fraction of a second visual disturbance can be the surface expression of a vascular event happening behind your eye. The retinal artery is a direct extension of cerebral circulation. What happens there is a window, quite literally, into what's happening in the vessels supplying your brain. A temporary blockage in one of those small arteries causes exactly what you just described. Your vision tells you about it for less than a second, and then the flow restores and the signal disappears. The event looks minor. It is not minor. In some patients, it's a precursor. The body compensates and resumes normal function, but the underlying instability that caused it, the plaque, the pressure, the irregular flow, that is still there. The accumulation happens silently. It always has. And that visual flicker, easy to dismiss as eye strain or tiredness, is one of the few times your circulation actually surfaces from beneath all that compensation and becomes visible. If this has happened to you more than once, even once, please do not wait. Now I want to talk about something that almost every patient I have ever seen after 65 has experienced, and almost none of them have thought to mention unless I ask directly. It's the morning stiffness that lasts too long. Not the normal ache of getting out of bed, not the tight lower back that loosens up after 10 minutes of moving around. I'm talking about stiffness in the hands, the fingers, the wrists, sometimes the shoulders, that persists. That's still present 45 minutes after you've been awake. That seems to ease only after you've been fully moving for more than an hour. The distinction matters enormously. Mechanical stiffness, the kind from sleeping in one position, from inactivity, from the normal compression of joints at rest, dissipates quickly. It's a hydration issue, essentially. The cartilage reabsorbs fluid as you move. 20 minutes, you're fine. What I'm describing is different. When stiffness lingers, when it resists movement longer than it should, the inflammation driving it is not mechanical. It is systemic. The immune system is involved. And after 65, the range of conditions that produce this specific pattern, prolonged morning stiffness in the smaller joints, include some that are entirely treatable if caught early and substantially harder to manage if ignored for 2, 3, 4 years. I've had patients who spent 3 years attributing this to bad weather or sleeping wrong, who came in and within a single blood panel showed inflammatory markers that explained every morning for the past 36 months. That's not a failure of medicine. That's a failure of the symptom being taken seriously. The body compensates around the inflammation. It learns to move through it. People assume if they can push through it, it doesn't count. It counts. This next one is harder to describe because it lives in the periphery of awareness, and people often feel almost embarrassed bringing it up. There's a word a lot of my patients use. They say they feel off. Not sick, not dizzy, not in pain, just off. A sense of internal displacement that they can't quite locate, as though the way they occupy space has subtly shifted. Sometimes they call it lightheadedness, but that's not quite right. It's more like a mismatch. The head moves, the world catches up slightly late. The floor seems just barely less certain than it should. It's not vertigo. It's not a spinning sensation. It is something quieter and more diffuse, and harder because of that to take seriously. What this describes clinically is a disruption in the vestibular proprioceptive feedback loop. The body uses 3 systems to understand where it is in space: the inner ear, the visual system, and the proprioceptive signals coming from the joints and muscles in the legs and feet. After 65, the coordination between these 3 systems can begin to degrade, quietly, incrementally, in ways that don't announce themselves as anything dramatic. The feeling of being off is your brain receiving conflicting signals and doing its best to reconcile them. The compensation works most of the time. You manage, you hold walls more often, you slow down on stairs without quite registering that you've started doing it. You reach for surfaces in the dark without realizing this has become habit. Here's what most people don't realize. By the time this compensation is visible, by the time you've started modifying your movement to account for it, the underlying degradation is already at a level that requires evaluation. The fact that you haven't fallen yet is not evidence that you're fine. It's evidence that you've been quietly adapting around a growing deficit. Falls after 65 do not typically happen because of a single bad moment. They happen because the margin for error has been narrowing silently for months or years. That feeling of being off is the margin narrowing. It's worth taking seriously before the margin disappears entirely. If someone you love uses that word, says they just feel off, can't explain it, brushes it away, please do not let that conversation end there. I want to shift to something that happens at night, because nighttime is when the body stops performing and starts revealing. There's a symptom I ask about almost routinely in patients over 65, and the response I get is almost always the same: mild surprise that I'm asking, followed by recognition. Some variation of waking in the early morning hours, not at a sleep stage transition, not from dreaming, but in the 2 to 4 a.m. window, with a racing heart. Not pounding, not painful, racing. A quickening that doesn't match anything you were doing in your sleep, that might last 30 seconds or 5 minutes, and then resolves completely. People assume it's anxiety. It can be anxiety. But when it's happening with regularity, when it has a pattern, when it arrives in that specific early morning window, it needs to be examined. The heart's electrical system has its own circadian rhythm. In the early morning hours, certain arrhythmias are more likely to emerge. including atrial fibrillation, which in its early stages can be episodic and entirely painless, and leave no trace by the time a standard EKG is done in a physician's office the following week. Paroxysmal AF, meaning AF that starts and stops, is one of the most underdiagnosed conditions I see in this age group, specifically because it resolves before anyone documents it. The accumulation happens silently with this one in particular. The episodes may be brief and infrequent at first. They are felt but not taken seriously. Months pass. The frequency increases, the duration lengthens, and the window for intervention, for rhythm restoration, for anticoagulation before a clot forms, for structural protection, that window is not infinite. What I'm describing is not meant to alarm you. It's meant to make you pay attention. Because a racing heart at 3 a.m. that wakes you up and then disappears is not your body overreacting to nothing. It's your electrical system telling you something about its stability. A continuous heart monitor worn for 2 weeks captures what an office EKG never will. If this is happening to you, that conversation with your doctor needs to include that specific request. Let me tell you what I actually watch for when I'm with a patient, because some of the most significant things are not in the chart, they're in the room. I watch how someone stands up from a chair, not because I'm testing them, but because the body tells the truth in that moment when the patient isn't thinking about being observed. The hips engage differently when the gluteal muscles have atrophied. The arms brace forward because the legs alone can't generate the force to rise cleanly. There's a brief, almost imperceptible stall at the top where the body searches for balance that should be automatic. I watch because the 5th symptom I want to talk about almost never presents as a complaint. Patients don't come in saying, "I think my muscles are failing." They say, "I get tired faster than I used to." They say, "The stairs are harder this year." They say, "I don't feel as strong." And then they qualify it because they've already decided it's just age, and they don't want to be dramatic about age. What I see clinically is sarcopenia, the progressive loss of muscle mass and function, showing up not as a dramatic event, but as a gradient, a slow drift downward in capacity that is dismissed repeatedly because at each individual moment the change seems small. It's only when you look back over 2 or 3 years that the drift becomes visible. The reason this matters urgently is the downstream cascade. Muscle loss is not just about strength. Muscle is metabolically active tissue. It regulates insulin sensitivity. It protects the skeleton. It supports the cardiovascular system during exertion. It maintains the core stability that protects the spine and, critically, reduces fall risk. When muscle mass falls below a certain threshold, the dominoes become easier to knock over. A fall, a fracture, a period of immobility, more rapid muscle loss from that immobility. The cascade is well documented, and the best time to interrupt it is before it begins. If climbing 1 flight of stairs now requires a recovery period that it did not require 2 years ago, that is a data point. That's the body communicating through diminished capacity instead of pain. And the body compensates by doing things with less, arriving at the same destination with more effort, more bracing, more recruitment of secondary muscles, until one day it can't compensate anymore. You don't want to meet that day without having prepared for it. The 6th symptom is one I hold with particular care because of how it tends to land emotionally, and I want to approach it that way. Memory retrieval delays, the tip of the tongue experiences, the momentary blanks where a word or a name simply will not come, are normal. They happen in younger people. They happen more frequently after 60, after 65. The brain's processing speed changes. Retrieval pathways slow. That is age, and distinguishing it from pathology is genuinely one of the harder clinical tasks. But there is a specific pattern that I pay close attention to, not occasional word retrieval failures, but the loss of a narrative thread mid-sentence. The moment in conversation where someone who is clearly intelligent, clearly articulate, clearly engaged, simply loses the sentence they were constructing. Not the word, the sentence. The idea itself seems to have slipped out of working memory before it could be finished. This is different from forgetting a name. Working memory, the ability to hold a thought in active mental space while doing something else with it, while continuing a conversation, while navigating a moment, is one of the earlier functional capacities affected in the cognitive changes that precede clinical diagnosis, and most people who experience it don't recognize it as something worth reporting because it resolves so quickly. The sentence comes back. The thought returns. The moment passes. What I watch for is frequency. How often does this happen? Is it increasing? Is it showing up in situations where it never used to? In calm, familiar conversations, not under stress, not when tired? Is the person beginning, subtly, to avoid complex sentences, to speak in shorter structures, to let other people finish thoughts they've started? These are patterns that emerge slowly and are almost invisible until someone is specifically looking for them. I'm not telling you this to create fear. I'm telling you this because the window for intervention in early cognitive change, for lifestyle modification, for vascular optimization, for the risk factor management that genuinely makes a difference, that window is real. It exists. And it is only useful if you step through it. If you notice this pattern in yourself or in someone you love, please name it to a physician, not apologetically, directly. The seventh one I almost always save for last, not because it is the least serious, but because it requires the most trust to discuss: unintentional weight loss, not the weight loss from an intentional diet change, not the slight fluctuations of a few pounds. I mean the quiet erosion, 5 pounds over 3 months, 7 pounds over 6 months, with no change in eating habits, no increase in activity, no explanation that satisfies when you actually sit and think about it. After 65, the body's caloric needs do change. Appetite regulation changes. But weight loss without a clear cause is one of the clearest clinical flags I know. The body does not casually shed mass. When it does, quietly, steadily, without instruction, something is driving it: inflammation, malabsorption, an undetected process that is consuming more energy than it should. The accumulation happens silently, with this one more than almost any other symptom on this list. It is slow enough to rationalize, easy enough to attribute to stress, or not eating as much lately, or just getting older, and by the time it becomes undeniable, the underlying process has often had significant time to develop. I've seen it missed for a year, 18 months. In patients who are otherwise active, engaged, functional, not visibly unwell, because the body compensates, because people adjust without realizing they're adjusting, because the weight comes off slowly enough that the mirror doesn't shock you. It just gradually confirms a story you've already been telling yourself. If you have lost weight without meaning to, even 10 pounds, even over the course of most of a year, and you haven't had a complete workup, please schedule one. Not to brace yourself for something terrible, but because the earlier you know, the more options you have. And options at this stage of life are everything. If you've stayed with me this long, I want to leave you with something that I genuinely believe, not as a physician performing reassurance, but as someone who has watched human beings navigate this stage of life for a very long time. None of these symptoms guarantee a crisis. Some of them will have explanations that are entirely manageable. But the version of yourself that notices, that asks the question, that walks into a physician's office and says, "I want to talk about this," That version of you has a fundamentally different set of outcomes available than the one who waits. The body leaves signals. It's been doing it your whole life. After 65, the signals get quieter and the stakes get higher, and the distance between "I should probably mention this" and "I wish I had mentioned this sooner," that distance is not what people think it is. If something on this list landed for you, if one of those descriptions felt uncomfortably familiar, I want to hear about it in the comments, not because I can diagnose anything there, but because you naming it, even in writing to a stranger, is often the first step toward naming it to someone who can actually help. And if this was worth your time, if something here felt important enough that someone you know should hear it, I'd ask you to share it. Not for the numbers, because one person hearing this at the right moment and taking it seriously genuinely matters. The most important appointment is the one you almost didn't schedule.